Assalamu alaikum, the communication day. The first scenario, Mr. Jack, 65 years old, known case of COPD, chronic obstructive pulmonary disease for the last 10 years, with history of recurrent exacerbation and admissions. He was admitted 3 days ago due to respiratory failure prior to secondary to infective exacerbation of COPD. Last night, his condition was severely deteriorated and was put on bi-level positive airway pressure BiPAP with difficulty of weaning. The pulmonology consultant made a decision that his condition not fit for mechanical ventilation if needed, and only BiPAP will be used. You are the senior house officer of the pulmonology on call today. You have been asked to discuss this condition with Miss Kristen, his daughter. So, if you are ready, Dr. Muhammad, we can start.
Ready.
Okay, here you go.
Good evening, Miss Christine. How are you?
Good evening.
How are you?
Okay, I'm fine.
Are you fine? Okay. I'm Dr. Muhammad, one of the doctor here. Okay.
Okay.
Are you Miss Christine?
Yes, yes,
Okay.
sir.
Are you the next kin to Mr. Jack
Yes.
at 65 years old?
Yes, of course.
Okay. Do you have, before to start the discussion, I need to make sure that do you have any permission from the father to start this conversation?
Absolutely. Yes, of course.
Okay. Do you need anyone else to attend this meeting?
Yes, that's fine.
Okay. Miss Christine, would you tell me how much do you know about your father's condition?
My father has trouble in his lung since long time, admitted many time, and because he was old smoker, and every now and then he admitted, and sometime he had bought an assisted machine, and he improved and he go home for a while, then he go back. Sometime he need oxygen in the home.
Mhm. Okay, how much or how do you expect about the continuous care of your father?
Yes, as usual, sir. You sometime need to put him in the machine till he improved. Then he will be go back home very early after assisting him with the machine.
Okay. I appreciate, I understand your situation, and we are ready here to make everything easier for you and for your father. As you mentioned, Miss Christine, your father is a now in case of COPD. As you know, this is a long-standing respiratory or chest illness. Usually the air sacs inside the lung will become destructed for a long time, and the patient might present to hospital with recurrent attacks like exacerbation and admission as your fathers do. And occasionally, unfortunately, like your father, sometime they might be presented with serious exacerbation and deterioration, which might need admission to the continuous care unit, which is called ICU, and we are usually obliged in this situation to put the assisted device, which is the airway breathing support. Up to now, do you understand and are you following me?
Yes, sir.
Okay.
I find my father now is not improved by initial management with nebulizers and oxygen. Why didn't he put him directly to the, as usual, to the assisted machine, like every time?
I understand your concern, Ms. Christine. As you know, unfortunately, the condition now deteriorated to the more advanced state, and he is now in respiratory failure. And but make sure that every single member in this team, including the respiratory doctor and special nurse and the every other team in this group, they are responsible for your father's case and giving the best possible care. As far as the father's situation is not in a stable situation, and unfortunately, he was not tolerating the removal of the device. You get me?
He didn't put it on the device, sir.
Okay, we
I mean,
tried.
yes, why you don't put the assisted machine as usual and put the tube for him to take his breath well and recover soon and fast?
Yeah, I
Why?
understand. I appreciate your concern. I know how much hard for you to get this. Usually, the disease is in a critical situation. Our consultant, respiratory or chest doctor, have decided for this machine to be the only and the more powerful device for him, and to avoid the mechanical ventilation. And mechanical ventilation is the which is the medical term, but this is the invasive tube. Usually, we connect the patient to the tube, and the tube is already connected to the device, to the machine, and we are obliged at that time to sedate the patient. But as you know, the situation is now critical. We cannot enforce the patient to receive this invasive procedure, and it has benefit, but usually the problem or the this device has serious side effects. Occasionally, the patient might complain of infection, and already your father has infection in the chest, apart from the illness itself. And the device, occasionally, in case of invasive tube, can make the more trauma to the chest, like make the air inside the pleura, which is the space around the lung. Up to now, everything is clear?
Yes, doctor. Yes.
Okay.
Why
So
now cannot be, and why in the previous time it improved? He improved on this machine before. In the history, he was admitted before many times, and he was put it in the tube, and the tube helped him a lot. Why this time is not suitable for him?
I understand your concern, Ms. Christine. You are right. Previously, he was responding to the BiPAP device, but unfortunately, the disease is progressive, means gradually gets worse, and the patient might not respond to the prior therapies like before. And the aging factor also one of the reason that the patient might not get benefit too much from this device, because it needs the heavy exercise or needs the good chest effort from the patient in order to tolerate the device. But now the patient has this exacerbation and this breakdown. So in this moment, sadly to say, he cannot more tolerate the BiPAP like before, but we are trying our best with the continuous care from medical team, including the chest doctor and special ICU nurse, as well as giving
Doctor,
many other therapies.
doctor,
Mhm.
I need everything to be done. I don't want him to die.
Okay, sadly to hear that. And I appreciate all this thinking, and I am with you. Just make sure that we are doing the best for him. Regarding the death of the patient, it's unpredictable usually. We cannot judge on this because we don't know more about this situation. We have to follow. We have to see the response of your father to the BiPAP by doing investigation, including some blood test to see the improvement, and following his clinical status, like conscious and chest improvement. And let's see, and giving as well as giving the frequent optimal medical therapy to cover the infection inside the chest, which is one of the reason for his presentation now. Okay.
Mm.
Uh, so up to now,
Okay. So, doctor,
everything is going fast.
if this method without tube uh, is not helpful, he can maybe intubated later on, doctor. Can we put the tube for him if
I
this
appreciate,
method is not successful?
I get this information. I appreciate your concern. Miss Christine,
1
sadly,
minute left.
okay, sadly, your father's situation not in a moment to put the tube. This is the decision of the senior or consultant lung doctor, and we are giving the BiPAP as the optimal therapy for him.
Okay, doctor. If he uses method, we have an occasion next week for a ceremony marriage for my granddaughter. Can he attend this ceremony by this device, doctor?
I appreciate your concern, Ms. Christine. You know the situation now in a critical position. We can offer a phone call through a social worker to make if your father's condition improving a while. But up to now, the patient should stay inside the hospital until he receives the maximal care and therapies.
Okay, doctor.
Okay. Do you have
Thank
any
you.
more concern?
Okay, we
How
will wait,
much,
doctor.
How much did you get from our conversation today, Ms. Christine?
Yes, we will wait and see. This is I got that. If he not improved
Okay,
from,
time is
so
up.
will be.
Okay.
Time is up. If I give you Dr. Muhammad 1 more minute, what you will discuss?
Wallahi,
Okay.
discuss. I
I
will
mean,
be
okay,
insist.
Doctor,
If I
Dr.
insisted to
Dr.
to do.
Muhammad
Mm,
Dr. Muhammad Serdar. Yeah, let
okay.
him answer.
I will,
Sorry, Dr.
okay.
Muhammad.
mm.
I will discuss the palliative care for the patient.
Perfect. If I add another 1 minute, what you will discuss?
DNAR. Sorry.
If I add another 1 minute, what you will discuss?
Um, mm, DNA. Okay. Advanced directive and lasting power of
Perfect.
attorney.
What you are waiting for?
Oh,
These
sorry,
three
sorry.
things you have to do.
He has too many concerns. Yeah, I'm obliged to answer everything.
Okay.
Yeah.
Well done, Dr. Muhammad. Thank you.
Yes.
Okay.
Okay, let's hear Dr. Muhammad Good comment, then I will comment.
Yes, yeah, the first comment here, yes, you approach the case perfectly, supportive, empathy, discussing the side the best interest of his condition, the good thing for the BiPAP and the bad thing for mechanical machine. His case is not like before. He till now is become more advanced and become more frail. It will be more difficult to be weaning this time, not like other before. يعني this is the issue. يعني إن هو كل مرة intubated ويحصل له extubation. This time maybe he will be put the tube, but we cannot remove the tube easily for this condition now, not like before. This is the issue, and for that for the best interest for his condition, the lung consultant choose for him BiPAP, and this BiPAP, if he's not succeed, finally he will not let your father die. Finally, we yes, sometime we re-evaluate the condition, and if he need to be tubed, that time the lung consultant will decide for that time. But right now, he's not in need to do the intubation. يعني this is the answer. ان احنا دلوقتي for the best interest he need non-invasive only because his condition is very frail. But in the future he might be re-evaluated by the lung doctor, and at that time he might decide for him the tube if his condition become more deteriorated. يعني that time, but this is the decision of the lung doctor. Right now he doesn't need intubation. يعني this is the answer. وانت ابروتشنج السايد افكت بتاع الميكانيكال فنتيليشن فيري ويل، اللي هو الميكانيكال اسوشيتد انفكشن او الهوسبيتال اكواير انفكشن، والسايد افكت اللي بيحصل تروما، ويحصل السايد افكت بتاعت الانتوبيشن which will be less in case of BiPAP يعني. فده برضه نقطة very good approached. موضوع ان the decision of the treating team is not the decision of the relative. This is good. و... وموضوع ان هو دلوقتي إنه ممكن لو if improved، لو انا عايز مثلا after 1 week عندي occasion. Yes, there is transportal device for BiPAP. Yes, if he improved and his oxygen level in the blood become okay, we can let him go by the transportal device BiPAP to attend the occasion of your granddaughter. Congratulations for this marriage. تهنيها طبعا. and he can, if he is tolerating and the oxygen level become acceptable, he can go by transportal device to attend the occasion. دي برضو من ضمن الحاجات اللي مكتوبة، بس برضو انت حلتها عن طريق الايه الفيديو كول، ودي برضو مقبولة يعني. بس all of all يعني perfect يعني ما شاء الله.
Okay, thank you, Dr. Muhammad Gouda, and well done, Dr. Muhammad Sal. I ask you the last questions before this scenario, carrying the hidden agenda of possible 3 points to be discussed. First point, do not intubate. And of course, if we discuss do not intubate, we might also raise the issue of do not resuscitate. I don't know, Dr. Muhammad Gouda, if you didn't
هو
mention this.
هو مش مطروح هنا، ولكن المطروح هنا كمان ان هو دايركتيف ادفانسد دايركتيف كان المفروض
Yes,
يسالها يعني. هو ده
exactly.
اللي كان مطروح هنا، لانه ادفانسد موربيديتي، فمطروح ان هو
Yes,
يتسالوا عن الموضوع ده.
perfect. So these 3 points should be raised. Do not intubate. It's clear here. We will not intubate your father. So do not intubate, do not resuscitate. Always we are discussing both points together. Whenever you are discussing do not intubate, you can say even if his heart stopped, we will not do heart compression or heart massage or chest compression or heart massage. This is the first hidden agenda. The second hidden agenda, possibly the palliative. So we will just give him the oxygen he needs, but we will not intubate him. And it will be included in the zone of do not intubate, do not resuscitate. The second point you should raise, instead of asking what you get from my meeting, don't ask this question again, because you will waste time for something it will not help you. So what you will do, either advanced directive, because this is very important point. This patient might die in the next days, right?
Yes.
So you have to ask him or you ask her if he wish anything to be done for him regarding his medical care. She might tell you, yes, doctor, he want to die at home. He want not to be intubated. He wish not to be admitted. All the things will help you in the management plan. If she said, yeah, he said, I don't want to be intubated again, it will be perfect, right? Because this is our decision now. So it will ease the task for you. The second advantage, if she said no, he said he doesn't want to be admitted to the hospital at all. Okay, we will respect his wish. Please, we can arrange for you fast track discharge, so he will be discharged at home, and we might provide you something he need like oxygen or BiPAP or whatsoever, but he will be at home and we will not admit him again if his condition deteriorated, and let him die in his home and around his family, or his family will be around. Okay, this is the missed point you missed already. I want to just clarify them. Other than this, you try to approach well, as Dr. Muhammad Gouda said, but again, the jargons, you are saying the respiratory failure. Instead, you can say breathing failure. He need to be supported by a machine, and he need to be under some medication to make him calm, which is sedation. Don't say sedation. She doesn't know what is the sedation. Try to be as much as you can simple. Okay, Dr. Muhammad?
Yes.
Jargon. Yeah, still you need to work on the jargons.
No.
And the introduction, when you said to her, do you have the permission to talk about
This.
yeah. What if she said, no, I don't have permission? So what you will do? You'll be in trouble. I always said assume
Yeah.
that she is the next of kin. I assume you are the
But
next of kin.
but
Uh-huh.
Dr. Bassam, he was conscious.
So
The the patient
yes,
was conscious,
assume
competent.
that, yes, of course. Assume that we have permission to talk about his condition. Me and you. I am the doctor. Assuming that we got permission from your father to talk about his condition with you. So you are the one got permission, not she.
Mhm.
Okay, assume that. And the second point, if he's conscious, why you invite someone to attend the meeting? Still,
Yes,
yeah, his
he's very
confidentiality.
sick, and of course his mental status and respiratory failure probably he need the advanced directive as soon as they become well. He should assign for another a person or from friend or family to for living will or power of attorney. This is very important للعيان ده من الأول الدسكشن يعني لازم Amina, you know, you have a power of attorney for this patient or have advanced directive because this patient may lack the mental capacity very soon because of his lung condition. So you'll be able to take a decision for him if he need. فساعتها لكن هو البنت متعوده ان باباه بيخش المستشفى يتحط له تيوب ويروح ويعمل له اكستيبيشن، لكن المره دي الدكتور ما خدش الديسيجن ده وفضل النون
Okay.
انفيزيف. فهي دي كانت ان احنا نفرق يبين البروز اند كونز للنون انفيزيف عن عن الميكانيكال
Intubation.
فنتيليشن.
Yes.
بالظبط.
Yes. Okay, perfect, Dr. Mohammed. But I want you to clarify another point. Okay. Don't talk about advanced directive from the start. You can ask it at the end. As usual, what we are used to do. Ask it at the end, and you can say to her, I assume you are the next of kin, so proceed for the discussion. Don't say you are the lasting power of attorney now. You can also ask this question at the end. This is what we used to do, not at the beginning, okay? Not from the introduction. I mean at the end.
And
Yeah, go ahead.
no need to take social history from this patient, right?
No.
No
You
need.
can prepare her with a smart way. You will tell her your father already suffered from previous admissions. He's sick enough. He's not able to cope with his daily activity. That's why our consultant decided in the best interest for him not to make him suffer more or to be more suffering as already he suffered before. So what's mean, doctor? I want to tell you that we will not put a tube again inside his throat or inside his mouth to make him able to breathe. Okay, this is the way how to approach from the start. You can make it as also a breaking bad news. I don't have good news for you today. Why? Because your father is suffering, and our consultant decide in the best interest we will not go for intubation. You heard about intubation? Yes, doctor. Every time he's putting a tube inside it. Yes, I am afraid to say this time will not put the tube. This is the way how to start from the beginning, how to approach this decision from the beginning. Don't explain about his condition. She knows everything. She knows that he's COPD. He has a lot of infections. He was admitted before many times. You can make it as breaking bad news because you are going not to intubate him, and if you will not intubate him, she knows that he might die, right?
Yes,
Right.
yes. I was also doing frequent sympathy and empathy. I was
Yes.
thinking of breaking bad news, but I didn't open it like breaking bad news.
Yeah. But please, whenever you feel the scenario is like breaking bad news, do it as a breaking bad news way, what we learn already. So give a warning shot and
Silent.
build in
Okay.
silence. Same, yes. This is breaking bad news. You will not intubate this patient, and eventually he might die because this tube was saving his life. But now we will not intubate him. And in another way or another word, you might leave him die in the next time. If he admitted again and he needs the tube, you'll not intubate him, and of course, definitely he might die. And that's why she asked you, no, doctor, please do everything for him. I want him to survive. I'm afraid to say we will do our care by our machine only, but without putting the tube. If he will respond, it will be okay. If not, I am so sorry, we cannot do more than this. And we can do what's called do not intubate as well as do not resuscitate. This scenario is very tricky one, carrying a lot of tasks. First is do not intubate, do not resuscitate. The palliative, which is also included, so we'll be sure that he is pain free, he's not suffering more, and the tube will make him suffer. As you said, it will injure his airway or windpipe, and without any benefit. And the last task is advanced directive, lasting power of attorney. If you have time to talk, but you have to ask this question. Okay.
Oscar.
Yeah. Clear now, Dr. Muhammad?
Yeah,
Yeah,
doctor.
تمام. Oh, yes.
Okay. Dr. Muhammad Sardar, you can post your scenario and we can hear the comments, please. Anyone has comment, add it to my points. COPD is jargon. You can say your father condition is called chronic obstructive pulmonary disease. Have you ever heard about it? She will tell you, yes, doctor, I know it. It is the condition he's already diagnosed with.
Yeah, Dr. Bassem, I didn't ask for this because the sister was knowing everything about COPD. Yeah. He told to me that I know the father is complaining of COPD and or lung disease, and frequently he uses BiPAP. So for that reason, I didn't discuss about the COPD. Am I right or wrong?
Yes, yes, no need to discuss now. The point is talk about the further plan, not about the diagnosis. I told you, you will break bad news about not to intubate, not to resuscitate. Okay.
Yes.
There is another question. Yeah, good, perfect question. Is this end of life care? No, I don't think end of life care. Why I said it is not end of life? It is equal to palliative. Okay, why? When and what the difference? End of life care, they will tell you, frankly, we will remove the machine, and will let him die in peace. What machine? The BiPAP. Patient now connected to the BiPAP, and still he's maintaining breathing through BiPAP, but they will not intubate him. This is another story. Okay, if they said in the scenario, you have to remove the machine and we gonna remove the machine and we'll let him die, this is end of life care. End of life care, clearly. Okay, there is difference between palliative, which is okay, we will not intubate him, but we will give him other supports, oxygen and feeding and whatsoever. But in this scenario, you will keep him on the BiPAP, you will let him breathe. He might need oxygen, okay, but we will not intubate him. Okay, clear?
Okay.
This is DNR, yes, I agree. This is DNR, DNAR, do not attempt resuscitation, do not attempt intubation. Okay, so this scenario for do not attempt plus palliative. And once you mention do not intubate, please mention do not intubate. Do not intubate, do not attempt resuscitation. And once you mention both, means that you have to break bad news.
دكتور باسم،
Okay.
هل هو ما جابش سيره دي ان ار؟ هل انا افتحها؟ يعني انا يعني
Okay.
هل من
Firstly, Dr.
why-
Mohammed, if you can ask in English because we have
Yes, yes, of course.
Yeah. Okay.
يعني I think it's not wise to open the DNR in the scenario if it's not applied in the scenario. يعني it's not
Okay.
asked as a concern. يعني if
Perfect question. Logic. I will answer from logic point of view. Okay. Now this patient need to be intubated, and you will not intubate him. What will eventually will happen? What do you think? Now patient is crashed. Okay. You hear me, Dr. Muhammad?
Yes, yes.
Okay.
I
Patient
think
is
I refer this lung consultant. In that situation, if it's not improved, I will evaluate with the lung consultant. That time he will take another decision for him. If he is
no.
not
He
responding,
decided. No, Dr. Muhammad. It's clear. He decided not to intubate the patient. Clear. It is clear in the scenario. Do
yes.
not intubate, right? Okay. What if this patient collapsed in front of you? He's hypoxic, and he's bradycardic. What do you think? Will you do CPR, which is cardiac massage,
I need intubation.
without intubation? How
No.
come?
Hi.
It's logic, right?
Yes.
Yes.
Hello.
I think, Dr. Bassem, for this point, just we will not talk about DNR, but we will not give hope like Dr. Muhammad gave in scenario. He giving some hope to the relative that if condition, we will re-evaluate and we will change the decision.
Yeah, no need to
sorry.
evaluate. Yes.
Sorry, just to make things clear, I think there is some interruption here.
Okay, this is
It's
Dr.
two
Nazia, right?
scenarios.
This is Dr. Nazia?
Mayada.
Mayada. Okay, go ahead, Dr. Mayada. Yes.
So there is two scenarios in the
Yes.
palliative care management. It's a part of management is the palliative care management. So the palliative care management, the ceiling of care. That's the ceiling of care that is ward management. Ward management, that means the patient has a DNR. That means he cannot be intubated in the, he will not go to the ITU. Or intubated. So this scenario is a DNR scenario. Even if this is not in the scenario, that when you tell the patient family that this patient will not be intubated, that means he will not go to the ITU. He's not for the level 3 care. That means he's a ward-based care. Ward-based care, that means he has to have a DNR. So the scenario is a DNR, in fact. Either the patient, this is
Yes.
the ceiling of care. Okay,
Yeah.
so you will
Yeah.
discuss
Clear.
this. You have to discuss this.
Yes. Perfect. Thank you, Dr. Mayad. So it's clear now, Dr. Aisha. Dr. Aisha, you have any doubt
You know
about?
my opinion, Dr. Bassem. In the exam, it will be clear. He will write for you DNR.
Okay,
So
it
you
will
will
be
speak for what he will, because in
exactly.
exam he
Yes.
supposed in communication you will
Yes.
not use your own information at all. We
Perfect.
don't
Yes.
know about this is word only word. It's
Okay.
not TTU. Not
Okay.
just said what he
Okay.
write in the paper, and you can, but don't give hope because he give hope
No,
to
no,
the
no.
relatives that we will
Perfect.
discuss again the condition. No, it is
Yeah.
I'm sorry to tell you, in like him, in patient like him, the condition will deteriorate, and nothing we can do.
Perfect.
And he can giving spiritual support in the hospital and give like that because that is clear that is in the stage. So, but to discuss the DNR at this point without
Doc-
writing in the scenario, I think
Dr. Aisha.
I will
Dr.
not do.
Aisha.
Yeah,
The good thing here, the good thing, and you will be thankful they write for you, do not intubate. Do not intubate in the hospital. Definitely, the patient should be do not resuscitate or do not do resuscitation or do not attempt resuscitation.
but why you
How,
will at this point? Just
yes,
don't intubate.
how
Okay.
I will not intubate the patient, okay, without
Why
deciding.
you will go to the point if the heart stop? Why? He didn't write for you. Just discuss this issue, and the
This
scenario
I am agree
already
with
have a lot of
I
information.
agree with
Already
Dr.
the scenario
Aisha.
had a lot of things.
Yes, I agree with
So
Dr.
we will
Aisha.
not put another point to
Yes,
make
he
it
didn't
very.
this is the decision of the consultant,
Yes,
and
yes.
he
Salam
didn't mention the
alaikum. Yes,
consultant wish.
yes.
Alaikum
I think
assalam.
DNR is the medical team decision after assessing the patient. If there's no written in the scenario, there's no need to discuss about DNR.
I
This the
agree.
reason I think
Because it
COPD.
is a lot of
That
words, Dr. Bassem.
yes,
You will not discuss this only if the heart stop. We will do like
yes,
massage, and it can
It's
hurt
a
the patient,
yes.
and
it's
there is rib fracture. You will discuss a lot, and no
no, it's
time in
one
this
sentence.
scenario.
It's one sentence, Dr. Aisha. Whenever his heart stopped, we will not do heart massage. That's it. In the best interest for his condition. I will not
Okay,
go deep.
they can,
But
yes,
I
they
think
can say
I
it, but
can
I
to
think
say
if
that.
not said, I think they will not deduct about this point, yeah, because they
Yes.
didn't write it clearly in the scenario.
Sorry, just I want I clarify this from our work here, how we are working here in the UK. What we are doing that either the patient having a DNR, that means when I discuss with the relative at any time, this is a normal day scenario. That's when you discuss with the patient that your whatever, he will not be intubated. That means that he will not having the care of the tertiary care. That means the patient have DNR.
Yes.
If
Clear.
you don't
It's
discuss this, yeah, this clearly
the
you need to discuss this. This is the scenario of DNR, even if they didn't say that. Even they
doctor.
didn't say that. This is it because this is the level of care. This is what
Yeah.
we gonna give
Let,
him. If
yeah.
his heart is stop, we will not do anything. This is the
Yes.
DNR.
Perfect. It's just
Okay.
words. Yes. And
You have to, because either you resuscitate this patient or not.
exactly. And let me add to this point, Dr. Mayada point. Any form, any DNR form in the hospital contain do not intubate. It's one of the of the element to sign in the DNR form, do not intubate the patient. Okay, it's one of the elements. Do not intubate included in any decision or any form of DNR.
This is information, Dr. Bassem. You should know. You know that MRCP is exam for all the
No, but
specialties, even the
both of them
dermatology.
are
And
together.
yes,
Dr. Aisha,
this
we
is
discussed this.
information. You should know to say. So if they need you to say, because they didn't exam this in this station your information. They just how to deliver the written information that they give to you. How to
It is the
deliver
task
it.
here, Dr. Aisha. It is the task here. Do
If
not
the task, they
intubate.
will said it is as a
Yes,
task.
this is the task here. Do not intubate. So, in
Just
favor, do
said
not.
not intubate. Why we will said no, we will not do heart massage.
Of course, because it's expected. Whenever you will not intubate him, expected his heart will stop. As I said,
Even expected. Just said what they
no.
said.
If you didn't explain it next time, if the patient, his heart stopped and will not do massage, they will complain because you are not clear in your management plan.
Maybe
Do not.
because this scenario is not a true exam scenario, so he deficient in information. Okay.
Okay,
Excuse
let's
me.
hear Dr. Dalia. Yes, please, Dr.
Hello.
Dalia.
مساء الخير.
Hello.
Dr. Aisha, hello, and everyone. Just to reassure you all, I've asked an PACES examiner for this similar scenario, and they
Okay.
didn't mention DNR. Okay, and she replied very clearly. I have to mention that just a sentence about the DNR. What Dr. Basim said exactly. There is, by the way, in every plan of in every scenario, you have to think what the plan of management. So you need to mention anything, at least a phrase about the plan of management. Okay, so the examiner said to me, it's need to say, yeah, the plan is whenever his heart has stopped, we wouldn't do a cardiac, we wouldn't jump on the heart, on the chest of the patient to resuscitate or restart his heart. Okay.
Yes.
Okay.
Okay, perfect.
What
Thank you,
if
Dr. Dalia.
if we said, I'm sorry to tell you that the condition, we expect that it will deteriorate, and I'm sorry, there's nothing we can do to him
Yeah.
if the condition deteriorate.
By the way, Dr. Aisha, most of the families are educated now and they are Googling everything. What to do if the heart stop, what they know about CPR, by the way. So I faced many times in ICU, family coming to me and honestly they are saying, Doctor, will you do CPR to my father if his heart stopped? I'm wondering, how do you know about CPR? So they are aware about everything. They know everything and they want you to do the opposite. So that's why they read about it.
Yes,
So
yes.
you have to be clear that if his heart stopped, we will not do. And this is expected. If you will not
Just I
intubate,
said if he deteriorate,
okay,
we will
okay,
not
Dr. Aish. Okay.
know any benefit from anything we can do. We can
Okay,
say like that.
what is
It is
Okay.
anything?
not. It is
What is anything? You have to be clear.
because
Dr. Aisha. Okay.
if you will discuss, you will discuss more, Dr. Bassem.
No. Only this sentence. I didn't
Um,
explain more. Okay, go ahead, Dr. Dalia.
Aywa, just to say something about that. By the way, you have to be precise, and you spoke very clear to the patient. In UK, there is no way to say we have no. That's just to the patient or to the, yeah, next of kin or the relatives. Something like something floating. No, you have to say it very clear.
Mhm.
Okay,
Mhm.
so
Mm.
our consultant in the ward, she's examiner, and many times said to me, many candidate fail the exam because they are not
Clear.
clear,
Mhm.
they are not precise, and you and during the exam, do you know how the surrogate will react with you, just in case you just say the way you are saying that, they will ask you again and again and again. You didn't
Yes.
understand why they ask you many times, because you were not clear.
Yes.
Got it me? So be
Yes.
careful, please. Be
Yes.
careful.
Yeah.
They are waiting for keywords. Please
Yes.
be aware of keywords, okay?
Yes. Perfect. Thank
Okay.
you, Dr. Dalia. Perfect. Thank you.
Okay, thank you
Okay.
for all. Thank you.
Okay, always this discussion is really beneficial for all of us. I know that there is some conflict between me and some doctors, but please go and try to get the benefit of this discussion. Make the things clear for you. So I think now in this scenario, it coming many times, and it's a high yield topic. COPD with recurrent infection, or pneumonia with recurrent admissions. So what to discuss? And they wrote for you, discuss the palliative or whatever. You have to speak clearly about the management plan. Why? Because if you didn't speak about this point particularly, they might fail you, because this is the future expectation of the condition. The patient might come again, and you will be in trouble. What to do if you didn't be clear? You will be in trouble in the next time that you will not intubate or you will intubate. The family aware or no? You have to know. You know, whenever I am in ICU and I'm receiving a patient dying, his heart rate is decreasing, blood pressure is decreasing, 3 vasopressors, I always ask my previous colleague, is the family aware about the expectation? Why? Because I am the one who will deliver bad news. I will call them, your father died. If they are not clear about this idea, I will be in trouble. I have to ask this question because I am the one who will deliver the bad news about this. So suppose the previous colleague or previous shift explained already the management plan that he's dying, we will not intubate, we will not do CPR or whatsoever. Clear now for all?
Yes, Dr. Mohammed. Dr.
Okay.
Basil.
Okay. Perfect. Let's go to the next scenario.
Where is the scenario one?
Yeah, here. Mrs.
Dr. Basil,
Yes, Dr. Sami.
yeah, excuse me for this primitive question. I'm sorry.
Okay, yeah, sure.
Is the do not resuscitate part of every palliative scenario?
No, not every palliative therapy. Palliative scenario with long-term expectation, maybe it will include DNR or not. For example, patient with cancer, and he might be living longer. But another scenarios like our scenario today, he might be admitted again for another intubation, and now this is the time to talk about do not intubate, so do not resuscitate one of the elements you have to talk about. But for long-term palliative, patient might live longer. Either they will write for you, do not resuscitate. But for sorry, there is some echo. So if for the long-term palliative care, they might write in the scenario task that to talk about DNR or not. So it's not one of the point you must talk about. It might be yes or no. Clear?
Yes, clear. Thank you.
Unless they wrote for you, discuss it, you have to discuss it. But if not, you might guess it, but it's not a necessary point to discuss. Okay, the scenario, Mrs. Almori is 28 years old lady who recently came to the emergency department because of blurring of vision in her left eye. Previously, she had been seen in the emergency department with mild tingling and numbness in her arms and discharged home. This time, she underwent a lumbar puncture in the emergency department and an MRI that showed multiple demyelinating plaques in the periventricular areas consistent with multiple sclerosis. She came today to discuss the result of her investigation. Your task is to answer the patient questions and help her to understand the new diagnosis and further plan of management. Please, Dr. Muhammad, do it in a perfect way. It's clear, and we just discuss how to counsel about the disease. Okay? Let me know if you're ready, Dr. Muhammad. Good.
Scenario written paragraph.
You didn't see the scenario? The scenario is here. Yes, Dr. Muhammad, send it again. If you can't read, I will send it to the WhatsApp group.
Please send it to us, group, please.
Okay.
From here.
Here you go. It's in the group now. You can read it. Can I do this scenario? Sorry, Doctor. This is Dr. Mayada, right? Next communication day, Dr. Mayada, I will give you the opportunity, okay? Sorry, because already selected. Okay, next communication after tomorrow, inshallah. Yes, very beneficial. Thank you. Once I heard a great advice from doctor here, let the surrogate guide you in communication. Yes, good. Thank you, Dr. Hatem. Yes, I agree with this totally. Let the surrogate talk with you, and from his talk, you might know what he wants you to talk and to tell. Dr. Dalia, I agree with Dr. Beth. Thank you, Dr. Dalia. Communication is not about knowledge, but rather to stick to what is written in the scenario. Just your task. You are only senior house of the interfaces. I agree with Dr. Aisha. Okay, we explained it, Dr. Muna. I guess you understood what I mentioned earlier. I agree DNR is a hidden agenda. Yes, Dr. Salma. No, if not scenario, no need. We discussed already, Dr. Aisha. Especially the road, do not intubate. Okay. If you're ready, Dr. Muhammad, we can start. I think we can offer psychological and social support. Perfect. Yes, we have to support as much as we can. And you have to ask also who's living with your father, who's dependent on your father, because maybe in the next days or maybe the next month, he will not living with them. So if his mother or her mother dependent on him, you should support her mother. And regarding the point of attending an occasion, you can offer, as Dr. Muhammad said, we will assess your father next week. We don't know what will happen next week. Maybe he will be fine. Maybe he will be deteriorated. We don't know exactly. And the good thing here, there is a gap between the admission and the occasion. You will be in trouble if she insists on tomorrow event or occasion for tomorrow. What to do? To discharge the patient on oxygen or to allow him to see the event by social media or video call. So the best thing is to always to be diplomatic. So if there is meeting or something in the coming days, we don't know that time if he will be fine or not. But in the current condition, I am sorry, he cannot go or he cannot leave the hospital. But if she insists and insisting to take her father, I'm so sorry, or I'm afraid to say this is the decision of your father. Let's discuss with him his condition, and he will be the one decided. But again, you can offer the social media also here, video call or whatever. Clear now? Dr. Muhammad Good, are you ready? The discharge or discharge against medical advice, one of the tasks in the exam. And it will be clear task that discharge against medical advice or insisting to be discharged. It will be different scenario and different task. So you will speak all the scenario. Please let him leave. No, I will not. Please, he has something to do. Or the patient himself. I have something to do. I want to visit my son. I want to attend my son's birthday. So it will be another scenario and it will be clear task away from what we are
Because
discussing.
Dr. Bassam, in DNR scenario, there is some concern that they will ask, the family will ask to take the patient if no hope, and they will not do anything for
Yeah,
him.
this is another thing. We
Yes.
want to take my father to die at home or to be with us. This is another thing, and you will be agreed if his condition suits for that, yes, we will arrange fast-track discharge. We will try to let him go home and to
We
die.
will discuss this with the consultant. If the scenario is DNR, yes, they have the right to know to do that, but this issue should be arranged with the consultant with which arrangement.
Okay, not only DNR. Any patient want to die at home and this is his wish, yes, let's do it. Okay, not only DNR patient. It will be like his
Yes,
wish.
yes, I know, but
Yeah, okay.
usually it raised in DNR, yes.
Sometime with DNR, sometime with patient.
Palliative or end of life
Yes.
care, all this, yes.
Perfect. Yes, yes. It's one of the concern. Yes, you're right. Okay. Dr. Daria wrote for DNR scenario, either direct task or hidden. Most probably the patient with comorbidity and he is critically ill and severe condition, not responding or no improvement with treatment. Yes. We discussed this point, Dr. Daria. Thank you for clarification. But we talk about this point. And this is different from palliative end of life care, which means you will remove machines or you will withdraw treatment and medication. So this is the difference between both palliative and end of life care. Dr. Muhammad Gouda, we are waiting for you. Dr. Muhammad, you are here?
Yes, I'm here.
Okay. This is Dr. Muhammad Sardar. Dr. Muhammad Gouda, you are here? Dr. Muhammad. You are mute, Dr. Muhammad, if you are talking.
Where is it?
Okay. Ready?
1 second.
Okay. I will give you one more second. Finished already.
For Dr. Muhammad, about the scenario, if you will ask about the advance directive and the power of attorney, you will not ask by this name. You should
Yes.
say like written wishes or
Yeah.
any. Is he nominate anyone to take his
Exactly.
decision apart from him like that? Yes.
Yes, Dr.
Just
Raj.
for more clarification. Yeah.
أنا صوتي واضح كده؟
Yes, clear.
Yes.
Yes, yes. Ready?
Yes. Hello
Yes.
there.
Hello.
My name is Dr. Judah. I'm a special house officer of neurology department today. Are you Mrs. Almori?
Hi, doctor. Yes.
Yes. Hello, Mrs. Mori. You are 28 years old, is it right?
Yeah.
Today we are here to discuss your medical condition. Is it okay with you?
Yeah, it's fine.
Okay. Do you want anyone from your family or friend to attend your this session?
No, I
If you
need to be
want.
alone. I need to be alone.
Okay. I would like first to know how much you know about your condition and what your expectation.
Okay, doctor, since a long while, I have some heaviness in my arms and feeling some numbness and pins sensation, pins and needle sensation, and I have some trouble in my vision. I went to hospital frequent times, but nobody told me what's going on. And I have done many investigation and including my head scanning, and they draw some fluid from my back, but I don't know the result. I guess I might have some infection in my brain.
Okay, I appreciate that. I'm sorry for that, what happened to you. The result of your investigation, all are obtained now. And I'm sorry is not as we hope, Mrs. Almori.
Why? What's going on, doctor?
The MRI, the imaging MRI revealed that you have some disease is related to disorder of your defensive system that's supposed to attack bugs and germs to defend your body. It attacks your nerve cables instead. And this disease called multiple sclerosis.
But why was multiple sclerosis not diagnosed during my first visit?
Okay, this is very valid concern. I appreciate that. Usually, this disease starting like gradually and attacking some nerves and going on and off. How can we diagnose that? First of all, it may subside without leaving any evidence of that, but it come back. And when it come back, it attack some areas, which is usually it attack this defensive system, start to attack some areas of the nerve cables of the eyes, sometimes the brains, in the special area in the brains, and also in our main nerve cable in our back. I am sorry to tell you that. And this is the image that has been discussed with the nerve doctor and reviewed with our radiologist, revealed that this result is go matching with this condition, typically of multiple sclerosis. Do you want me to explain more about that?
No, everything's clear up to now.
Do you want me to explain more about why multiple sclerosis?
I get multiple sclerosis, but what's going on with me in future? I need. Will I be disabled soon, doctor, about in this disease?
Yes. Now, I know this is this chronic disease going on and off. I told you before, and if it's not untreated, it will lead, of course, in the future to disablement if we not treated and control the inflammation perfectly. So what we will do for you now to control the inflammation emergently, to keep your eyes, your vision, and your nerve cable of your eye, so we will be able to maintain your vision of your left eye and to avoid any disablement. This is our plan. This is what's called induction. We will give you some treatment called corticosteroid. You have heard before corticosteroid because this medicine has bad reputation.
I didn't hear of this medication.
Yes, this corticosteroids we given only for short time, and before we giving this medicine, we just test you don't have diabetes, you don't have glucose problem, you don't have, and also we let you know some the benefit and the side effect as this medicine, of course, to control only the inflammation. After that, there's a big revolution about the medicine in this respect, in this disease. There's a lot of medicine now will help you to control almost the condition and will lead you to live near normal life if you comply on the medicine with the nerve doctor.
But doctor, how long will I be on this medication?
Unfortunately, Mrs. Elmori, this is a chronic disease. And I think the good news here that if you take the medicine, you can control the inflammation of the nerves, and then at that time you will live a complete near normal life if you take the medicine perfectly. And while if you only have a flare, during the flare you will receive only the corticosteroids, the steroids. Is it okay?
Okay, yes, okay.
Okay, of course, this is the first important part to avoid the flare of the disease and to control the inflammation now. And after that, of course, you will assign appointment with our nerve doctor, maybe next week, to sit with him and to assign with him the plan of management with the team of doctors specialized in nurse doctor, nurse staff specialized for managing multiple sclerosis besides the nerve doctor and occupational health care worker, of course. This is important about how much this affect your job.
I cannot do anything, doctor, up to now because I'm too much stressed on
I'm sorry
this.
for that. I can refer to the occupational health care worker. He will give you the medical report and probably the sick leave for your condition. And after you control your case, you probably will go back your work. Otherwise, if you work, what are you doing for living for your job? What is your job?
My job is I'm accountant.
You're accountant. I think is not a risk job for multiple sclerosis because you know, this affecting vision. Sometime, if you are driver or you are a pilot, that time it will be a big problem. For your condition, after controlling the condition, you will go back your job. Meanwhile, we will give you like sick leave and of course, to control of the condition, then you can go back safely to your work. And this is another issue. Are you driving your car?
What was that, doctor?
You are a car to drive? Are you driving?
No. I will not drive by myself.
This is important not to drive nowadays, especially except after doing review with an eye doctor to give you a permission that you are seeing well too with the left eye. Is it okay?
Yeah, it's okay. Thank you.
Okay. Is you have any support in your home?
No,
They are
I don't need
they are doing well.
No, everything is good. No.
No need for financial
No.
support.
Dr. Basim. Okay.
Drinking alcohol? You have smoking or drinking alcohol?
No, I don't
Hello?
smoke or neither alcoholic. No.
That's fine. That's fine. Okay, now what we are going to do again to tell you that we just will take the medicine. To summarize, this is a multiple sclerosis. Your defensive
Doctor,
system.
I have one concern.
Please.
You know, I'm married and I want to plan to become a pregnant. Is it safe to do so?
This is very important point. I'm just about to talk about. If you are planning for family, you have to talk to the woman doctor with the nerve doctor to give you the medicine that is safe during your pregnancy. And this is because there's a lot of modality of medicine that sometimes is not suitable for doing in the pregnancy. So better if you are planning for getting pregnancy, you have to talk to your woman doctor and to your nerve doctor before starting, and to adjust the medicine for you to be able to take to be pregnant. My advice here initially to postpone this step except after controlling at least the flare. Yeah, not to get pregnant during flare. This is important. After you control the flare, then you have
But
to
doctor,
consult.
I have one more concern. What's the
What's that?
chance that my children will get multiple sclerosis?
This is a very important concern. I appreciate that. This is not familiar disease. This is not familiar disease, not running in the family. So it's not suppose that they will take the disease. However, there's there's this little bit increased risk maybe than general population,
But doctor, there is a
but not be inherited to your family, not inherited to your kids. So it's not familial. So no worries.
but there are two twins in my neighbors complaining of the same illness, I think. Both have them. I'm afraid.
Yes, as I told you, there's a little increased risk of multiple sclerosis. It increased than general population, but it's not inherited through genes. It is a risk more than general population, but no rules, no risk that no genes will be inherited to your kids.
Doctor,
Yes. Yes.
are the medications safe during breastfeeding?
Yes, this is the issue. I told you before, we are planning for that. We will modulate the medicine with the woman doctor and nerve doctor, what's called something called multidisciplinary team. This multidisciplinary team, this main group of doctors concerning that will give you the medicine that is suitable during your pregnancy, and sometimes they will give you the clear instruction whether to breastfeed or not suitable to give the breastfeed after getting your getting the child.
Yes.
Okay.
Okay.
Time is up. You want to add any concern, Dr. Muhammad Sardar?
Yes.
No,
I would like
that's
to.
it.
I would like to ask you if you have any other concern.
No more concern. Thank you, doctor. Thank you so much.
Thank
Okay.
you. So now we're planning for the induction. Then we assign with you appointment with our nerve doctor.
Time is up, Dr. Muhammad. Good. Okay. Well done, Dr. Muhammad. Perfect. Seem you practiced this scenario before, right? I guess so.
لا والله لسه سمعته بس من
Okay.
حضرتك، فأنا مبسوط يعني إن أنا
No,
طبقته
no.
يعني.
Yes, you did it great. Yes. Okay,
Okay.
we will try to correct some points, but you did great. Dr. Mohammed Sirder will start commenting. I will.
اتفضل.
Dr. Muhammad, thank you for this presentation. Really, it was perfect, and you were covering many things. But one point in regarding the way of communication, I mean the sympathy and empathy. Because I'm a female and I have loss of vision, you think this is not an easy thing to me, and I might lose a job, and I get some complication again, like disability. So you have to offer sympathy and empathy frequently. This is first, and give us some space, like pauses and punctuation, and check understanding during that period. Okay, because without giving this pause, the conversation will be one way. It's not a two-way communication. Okay. Apart from that, the information were covered totally. Everything was good regarding the management plan. It was perfect. Induction therapy, maintenance therapy, and social history also covered. Apart from this, pregnancy issues and breastfeeding. Nothing more than that. You did well. Thank you.
ثانك يو والله. هو دي مشكلة عندي الحقيقة.
No worries.
فحضرتك انت حطيت ايدك على المشكلة. You put your hand on my weakest point. Yes,
No worries.
I don't have a good support
No, no,
يعني.
no.
No, you can
No,
improve.
no. Dr. Muhammad, you did great in talking details about how to counsel, but you are doing it in like student manner. You got it? So still you need to be practicing more, to be more trained how to use sympathy and empathy while talking. But you cover everything related to this task, which is a counseling about the disease. You got this point. As Dr. Muhammad said, you have to be sympathetic and empathetic. Let me correct some points also. Whenever you have patient complaining of a disease and it might not affecting her job, don't judge on her job. Okay, so you said, I guess this is not affecting her job. She will tell you, no, doctor, it's affecting. How do you know? So don't, in another word, don't be judgmental. Don't say, I guess it's not affecting you, like a driver, or like, no, it might be more harmful for her than driver, for example. Right? Okay, this is first point.
What I mean, this point, it's not banned
No, it's
to work as
even,
an accountant, but it is banned to drive a truck or to be a pilot. In that situation, she has to stop. She has to be
I know,
allocated. But
I
in her
know.
condition, she is not a high risk job. So
Perfect. This is from your side. But from her
yes,
side, she might tell you, it's everything, doctor, for me. I cannot do anything because of weakness. I
right.
cannot see the computer. From your side is something, and from her side is another thing. So this is not my point. Don't judge on her job. Okay, good.
Okay.
She. You can ask what the impact of this job, of this disease on your job. If she will tell you nothing, doctor, I am fine. Okay, it's okay. If she said no, doctor, I am suffering, so be sympathy and tell her I'm so sorry for your suffering. I will try to help you in this regards. That's it. Okay. The second point, yes, the driving. I guess you ask about the driving. If she said yes, I am driving, what you will do?
I will stop her driving. Advise him to call the DVLA
Perfect.
to
Yes.
notify them about her eye condition and to review with the ophthalmologist, the eye doctor, to give her a
No,
permission
that's
whether
enough.
to.
No. That's fair enough
No
to
need.
tell her, inform DVLA. Yes, and the DVLA will do their job. By the way, this is not your job. The job of DVLA either to allow her to drive or not. Okay, so please stop your driving. It might harm you and harm others, and please inform DVLA. They are the one will follow you, and they will follow your permission to drive or no. That's it. Okay, this is regarding the second point. Of course, again, any point, any female in childbearing period, please address this concern. Write it in your paper before going inside the station. You will forget it. I know you wrote it in your scheme, but whenever you go to the discussion, you will forget it. So please encircle it in your paper, and whenever you finish your task, ask it. Before she ask it, it's good to ask from the surrogate side, but it's better to be asked from your side. Okay. The third thing, I think you covered the task as I explained earlier about the pathology and the manifestation and the complication. And the good thing here also, you said it might let some disability, which means you might be in the future difficult or disabled or difficult to cope with your daily activity. You have to be honest about that and be sympathetic and empathetic again, because this patient with a long-term disease, it might leave some disability. Okay.
Well,
As you
doctor,
said, yes, go ahead.
sorry, doctor, go ahead. Sorry.
No, no worry. I'm talking. If you have,
Dr. Muhammad, loss of vision is a breaking bad news. Simply.
yeah, he did it in Breaking Bad News way.
Yes,
Yeah.
I did it
Yeah.
in very bad.
Yeah.
I did it
Yes.
is a grave. I give you a silent
Yes,
moment, and
yes,
Very
you
good.
was very rapid to ask again, and I told you this also. She has some blurring in the left eye. I told her this is emergency. We have to take induction. We have to keep your eyes.
Yes.
We have to emergency with the eye doctor, of course,
I mean,
to keep.
to the audiences here in this meeting, the
yes.
loss of vision is a breaking bad news. It's clear, simply.
The multiple sclerosis itself is
But
Breaking
it's
Bad
a
news.
MS, yes, is a multiple. Yes, is a
Yes, it's why, because it's long-term disease, progressive. Some types of multiple sclerosis might be dangerous, and it might be affecting the vision or weakness or whatever the type of secondary progressive or relapsing remitting, whatever. So it's one of the Breaking Bad news, and I prefer Dr. Muhammad Gouda to mention the disease name before explaining the disease. So in this way, I'm so sorry. I don't have good news today for you. Why, doctor? What happened? The result with me now, and it shows that you have a condition called multiple sclerosis. Then golden silence. Then again, have you ever heard about multiple sclerosis? No, doctor. Oh my God, what happened, doctor? What is this? Let her react. Then now you explain about the multiple sclerosis. Okay, multiple sclerosis is one of the condition in which your defense system, as you said exactly, attacking the nerve cable instead of attacking the bugs and blah blah blah. Again, be sorry for here. We are here. Don't worry. We will be with you in this journey. We will try to support you as much as we can and blah blah blah. And the disease coming as
ما
exactly
عملت يا
was.
باشا يعني I give the bad news. Then I give reassurance that there is a revolutionary change in the modality of management, and there is a good news about the treatment that may lead you to live near normal life. I give the bad news, and in the same time, I come back that tell if it's
Yes.
untreated, will be disablement. But if treated well, new drugs now available, and you will assign appointment with the nerve doctor. He will give you this medicine. I give the hope in the same time, but
Yes,
يعني
I
to balance
agree.
the patient, to feel
I
the patient support. I give her support also.
Yes, but you are not sure about the type. So you don't know what is the percentage of recovery or being clear of symptoms, right? But you have to reassure and to say, we will try.
If he asked me
Yeah.
about this, should I tell him that is the 15% of patients may
No,
have
no, no, no.
disablement? This is some ratios in multiple sclerosis.
Yeah, you can say
Should
it one of the
he didn't
complications.
ask this. He didn't ask a concern of that about that.
Yes, you can say. I said it's
Yes.
one of the counseling point. You have to mention the possibility of every complication, but not in percentage, not in number. You don't know what exactly and what you don't know what the type. So don't give her particular percent like 15 or 10. There is some patient. Sadly I can say there is some patient that may live in a disabled way. I'm so sorry to say that. Okay, this is the only this is the way how to explain or to say it. Okay, One more point, the corticosteroid, I don't know why it was raised by you. It's not written in the scenario. Yes, there is possibility and there is management plan to talk about, but why particularly you?
Yes, she's in flare now. Flare, a flare in multiple sclerosis, we should start pulse therapy corticosteroid. But after confirming that he has no contraindication.
No, I don't think you have.
Yeah.
And it might be some pharmacological option, but without specifying steroid. This is my opinion. Okay, we will hear from Dr. Mohammed Serder if we need to talk about steroid, particularly here.
Doctor, I think because it's a breaking bad news and the patient already lost one eye vision, it's
Okay.
better to say the steroid because steroid is the main treatment in induction therapy.
Yeah.
Yes.
Okay.
Better to
This
say.
is essential. This is a life-threatening condition. We have to, in flare of multiple sclerosis, we have to give we have authority for that, and to talk about the induction and the side effect, and we have to talk about sometime that this bad repetition medicine may have some bone fracture in your hip, diabetes may develop, and some skin changes.
Yes, I
And
agree. If they
some
specify, I agree, Dr.
yes.
If they
If
specify,
he asked the corticosteroid, I will let her counsel for the medicine with the
yes.
dental doctor, but I will tell her that we are going to give you corticosteroid to control. Then we assign the proper management to the nerve doctor and the multidisciplinary team.
Honestly, if I am in your position, I will not choose a steroid itself. I can say there is possible medication can be given in your condition in the best interest, and we will sit with you in another meeting to discuss the possibility and the best interest for you. Because
The induction in the same session. يعني لو احنا ما ينفعش
No,
ان
I will
انا
not
اجل
talk.
الكورتيكوستيرويد.
It's
I will not
optional,
talk
Dr.
about.
okay,
Bassel.
let's hear
Yeah, I'm agree with you, Dr. Bassel.
other comments. Yeah, let's hear other comments.
Yeah.
Dr. Mayada, yes.
I will not raise the steroid things in this meeting. I will talk to him that I will arrange another meeting with you to discuss the possibility of the management plan. Because I just break the bad news. I
Yes,
want
yes.
him to absorb, her to absorb this first. And just another thing, just I want to comment. I think we need to give a hint about the type of MS itself. These diseases react different in different people, and not all people react the same. So it's maybe coming as a relapsing. It come as relapse, and maybe MS can progress. So different people react differently. We don't know now which type of people you are. That's why we need more counseling. We need to sit with you more, and we'll have a lot of meeting with you and with my consultant, and in another meeting, something like that. So to reassure her
Yeah,
that we
okay.
are following her.
Since they didn't write anything about the type, I don't know if you can
We
mention the
thought
type.
that there is it's react different. So
Yes, I know.
I don't want to give her a false hope that she will get better with the medication, because
Yeah,
there's
yeah.
possibility that it may be
Perfect. Yes,
progress.
perfect. I agree with this.
So
Yes.
just
So you don't
mention.
know the type exactly. So again, don't be judgmental on unknown type. So you are not able to give any clear future expectation about this disease now because you don't know what the type is ongoing. You're right, Dr. Mayad. I agree with you. But if you go more with the types of multiple sclerosis, you will spend a lot of time, and she might ask you, Doctor, what I'm having, what type I'm having.
No,
You'll be
like so these diseases react different in different people. So at the moment we are not quite sure how it reacts in your case.
Mhm.
There is many type of this disease. We'll discuss this later. So you will give her another meeting to discuss what type it is. This is your first attack. We don't know how it reacts.
Yes.
Most of the people, it reacts by relapsing and remission, and that means that it will come and go. And between these attacks, you will be having normal life. but we'll see that further. So you will give her a hint about what may happen.
Okay. Okay, good.
Probably, Dr. Maida, I agree. I told her it's the same, but in another language. I told there's a disease is coming on and off, and sometimes you are completely free, and sometimes it come in attacks. And during attack, we have to give some medicine to control the attack to avoid late disablement and permanent disability. That's what I mean by to control only the disease flare, and after that you have to follow to comply with the medicine, and to follow the nerve doctor with another appointment. This is the same plan of management. But what I have added is that I have to add corticosteroid because we are in emergency. She's going to lose her eye. That's what I mean. Yani. This is
Yes,
what I
yes.
mean.
We respect your opinion, Dr. Muhammad. I'm looking for another opinion just to know which is in favor to do.
The same اللي هو on and off اللي هي relapsing remitting. I give it in slang language, in language to
Yes.
understand of this the patient, the disease come on and off like this and like this.
Okay,
I
if
think
you
what
want,
Dr. Mayada means, Dr. Mayada means that there is another types of MS, okay? Like some progressing disease without remission. So we cannot just tell it is a relapsing remitting disease. We can mention
okay,
the things also.
yeah.
Yeah,
So
okay.
so you
Because we
cannot
don't know
assume.
about the type. Yes, we
Yeah,
cannot
Yes,
assume
yes,
this is the relapsing
but
remitting disease.
yes.
yeah, I agree. But in this scenario, it was like this.
Yes.
The patient come into attack, the first one, and then it become normal. Then
Yes,
it come with the eye symptoms, and he asking me why I'm not diagnosed in the first time. This is a concern.
yeah,
That's
yes,
why I have
right.
to tell
Yes,
him that this disease is come on and off.
Yes.
Okay.
معلش Dr. Batem, again,
Yes.
Dr. Dalia mentioned also, the plan of management is written clearly in the task.
Yes, I will ask Dr.
Yes,
Dalia now to talk
yes.
what she why she meant by this comment. Please, Dr. Dalia, what do you mean
In
by
the
this?
task, it is mentioned in the task, in the scenario. When they mention the task, they ask about explaining the diagnosis to the patient and the plan of management.
So,
Yes.
should be done.
Yeah, Dr. Dalia, please, what do you mean by that? My opinion before, sorry, Dr. Dalia.
Yeah.
I'm not, yes, doctor, go ahead.
Yeah, I mean you need to mention the highlights of the treatment. So at I don't know the name of the doctor. They try to mention in a way it's induction and maintenance. Okay, but we need to clarify that in simple language for the patient that whenever you have acute attack or something like that, contact your GP. That most probably you might need what is called steroid. Okay, just mention the name. We will give you the whole details later, just to know that what the plan of management, and then the nerve doctor will decide what kind of the kind of medication that you need to do just to prevent the attacks to come again, because as clearly you mentioned from your history that it's you have attacks and then it's gone and again. So to decrease the relapses, or what it called in medicine is relapses, so it's come and go on and off. So we need to most probably the nerve doctor will put you on the treatment to decrease this kind of relapse. Okay, so this is just only because they usually patient like patient with MS and ask for the management plan. They need to know that, okay, that no then we'll have a meeting with you to discuss more about your treatment with the nerve doctor. Just give the patient highlights, and you
Yeah.
will be on regular follow-up. We have a team, whatever you want, whatever it happened, we have a team to help. Okay, so for example, occupational therapy, because we wouldn't go deeply, but that just reassure the patient we have a team could deal with everything that might happen. We'll give you brochures and links to know more about the details. If you just let the patient, by the way, the patient will guide the scenario. They will hit you with the many concerns. Okay, so you will, at that moment, you need just to highlight things like that, and then there is ready-made concerns for you, and then you could clarify more and more and more. So most probably they will the patient will discuss about the outcome, okay, the job, and she might need to quit her job or her study or something. And I remember that I have a scenario with a patient. She's physiotherapy. She's physiotherapist student in her first year. Okay, so just in her first 2 months in the university, then she developed the symptoms, and just came to me to just ask, and she told me she was very worried and just keep silent for the whole meeting. Okay, so I just asked her, could you share me with your thoughts? I'm here to help. I could give you any hints or something. Okay, and just mention that I'm physiotherapist student doctor. That's mean what the meaning of studying that. I couldn't do that. Okay, so hit me with many concerns at that time. So just prepared to answer question like that. Okay, thank you.
Very good.
Perfect. Thank you, Dr. Daria. So what I understood now from Dr. Daria, at least give idea about what's the management plan will be for. So in acute condition, we have to do or to do induction by steroid. And in the chronic term, you can take medication which is called DMAMS, disease modifying agent for multiple sclerosis. And we will provide you a leaflet brochure about the details of management plan.
Yeah,
Exactly.
yeah, yeah. Okay, I will let you know what I've said to my patient. That's usually multiple sclerosis, was for short we call MS. Most of the people know MS, okay, here in UK. So it's a kind of disease, okay, affecting your nerve, and there is many type for that, and the progression of the disease is different from patient to patient. So in our clinic, we have usually we treat the patient holistically. So everything could happen. We have a plan for them. We will do always we have something to help, okay, but we can't guarantee how the patient will have, because it depends different from patient to patient. And just for the treatment, you will give a hint about the prognosis from the good and the bad, okay, and then it depends of the management. So as there's some I guess this case particularly, she might have relapsing remitting or secondary progressive.
Yes,
So yes, so this patient, she might be just relapsing remitting, which is good prognosis, or she might be complicated, and and then be like secondary progressive. Okay, so this is bad prognosis. So we don't know at the moment. So we'll wait and see, and we'll keep you on regular follow up. Okay, whenever you have any concern, we never have any.
yes,
Yeah.
yes. If he asked in his concern, how much doctor of disablement or disability, I think there's some percentage approaching 15% of people with multiple sclerosis. In spite of management, they still have or experience disability, permanent disability. And the majority of patients will, if treated well, it will avoid this complication. But unfortunately, still a percentage of people still have the disease, still has disability in spite of the management.
Yeah.
This is what's called the prognosis. Of he asked me about
Yes.
how much you have the disease, how much this
I
it's
will
a bad prognosis.
honestly, doctor, I will avoid to mention any figure, but I will say most of the patient will have good prognosis, but the other smaller percentage, or the lesser amount of I mean
Yes.
the people, the less no okay, the most people will have good prognosis. The other will have, we could end up with bed bound or wheelchair. Okay, so I will give the worst and I will give the best. So it might end up with bed bound or wheelchair. Okay, so she knows that yeah, the range of the and people they might know, but that she need to know that most people have nearly normal life. Okay, many people have nearly normal life and have
Yes.
good prognosis. So it is really early to know. That I usually do. It's early to know. So we need to wait to see and to wait and see, and to know what kind of your disease that you have. So and what type. Okay, with time. So after that, but be sure every time you have a piece of knowledge, you need to reassure the patient after that. But be sure we are here to do to help you, and we have a team could help you. Okay, so just give reassurance after, because some with this is empathy and sympathy. Okay, with in a professional way. Thanks.
So reassurance is different, maybe from sympathy. Yeah, and I try to give reassurance, but sympathy, I have
I know.
difficulty. I have difficulty. Well, I don't know why. ما أعرفش ما.
Okay,
Training.
Thank you, Dr. Dalia. Yeah,
thanks.
I want to add to Dr. Dalia comment. Any specify of percentage like 15 or 20, and it would be wrong. It will harm your clinical judgment point.
Yes. Yes.
So yeah, don't say a clear exact percent or number. Just as Dr. Dalia said, most of people they might live near normal life, and there is some few percentage they might have disability. Don't judge how much or how many or how percentage they are. Clear?
Dr. Basim, I have a question.
Yes, sure.
Yeah, whenever we mentioned steroid, okay, we have to go further explaining about steroid. I think when
No, no.
we are mentioning steroid, it is a big deal, yani.
Yeah,
We
it's
cannot
big
just
deal,
mention steroid and go.
you can avoid that by
Mhm.
saying, I will give you leaflet brochure about the steroid and the side effects. Because if you're speaking steroid, it's a session, it's a station.
Yes, you're right.
Yeah. So in one sentence, you might
Mhm.
receive a medication called steroid. Have you ever heard about steroid? No, doctor. Okay, I will give you some leaflet brochures about steroid to read about it, the possible side effect, and how we will proceed with you in the next meeting.
Yeah.
Because you don't
Yeah,
have
but if
time
the
to
patient,
explain.
if the patient or the surrogate ask, we will explain more.
Yes.
It would be
we
the
ask for
task.
explanation.
It would be the task. So you will
Yes, you're right.
counsel about steroid. How? You will give everything about steroid, either indication and
Yes,
mechanism of action, the road, the
side effects,
frequency,
yes, you're right.
the side effect, how to avoid, and precautions. Yes.
Okay, thank you so much.
Most welcome, Doctor. Thank you.
Thank you, Dr. Bess.
Most welcome, Dr. Muhammad. Any question else from Dr. Muhammad Gouda or Dr. Muhammad Sarder?
Thank you, Dr. Basim.
Okay. Is the
Almost.
prognosis? Yeah, good question. So you can say outcome of the disease.
Outcome, yeah.
Outcome, yes.
Yeah.
Perfect.
And I think also the name is to name it is induction and remission. It will make your the scenario more
Jargon?
complicated. Just to be simple. And
Okay.
we have a medication if you have attack and the other medication
Yeah.
to prevent
Fo-
other attacks.
Perfect. Yes.
And
Golden
the
comment.
Dr. Muhammad, at first, you said, I am doctor, I think in neurology, I think, just to make it fixed start, I am a doctor here, one of the doctor
Yes.
here, just this
Yes.
word, and keep it, because
Yes.
you will start by jargon, and this will deduct, he will deduct the mark.
Yes.
Any
You're right.
jargon will deduct the mark. So make it fixed beginning, not because in exam this is a lot of stress. So this
Yes.
point will end with you in any practice after that in the exam. I am one of the doctor here and end this point.
Yes.
For the empathy and sympathy, keep some sentence and keep it in your mind to keep it a lot, like repeat it with yourself even.
Like here, Dr.
Like when he asks you, the most important point here, he will deduct for sympathy. When he asked, I'll be disabled, you didn't show any sympathy when your answer. You said like answer, yes, you will be, maybe you will disabled. So it is you should say, I'm sorry to tell you, yes, this disease in some condition can leave you disabled. I'm so sorry about this news today. I know this is how it is hard with you.
Perfect.
But we will keep eye on you, we will follow you, and
Yes.
we have a lot of medication can improve and let you live normal life. But it is too early to decide about this.
Perfect.
And about the job also, you said it is not impact you. He has problem in vision. Vision will impact all his life. Even you will ask him
Yes, you're
about
right.
whom, how this impacted at home and
Yes.
its job. Don't decide. And this point also should have a lot of sympathy and empathy. I know how
Yeah.
this is difficult with you. We'll support as much as we can, and we will provide you with much support, and we will give letter for your work and for the occupational department at your to your work. About also the management, you can say that we have some with group of doctors that include also the some specialists, so he will
Yes.
let your life easy with any problem this disease will affect your health by any time.
Perfect. Yes. Another support also here, social support and group support. I will provide you with some group support. They are having the same disease to share the idea together. They have experience about the disease. You
And
can
really,
show
we
them.
are like you, Dr. Muhammad. We write this sentence, and I keep
Yes.
it's like my name. Some sentence I
Yes.
just keep it like to be easy, to the scenario to be easy in some time. So I'll keep some sentence and I repeat it, especially in delivering bad news.
Yeah. What?
So we will repeat it every time you will repeat
Yeah, you'll be
the
expert.
information. You will repeat this sentence to show
Yes,
the
but
empathy. Yeah.
yes, I agree with Dr.
Yes.
Aisha. Just write it in your
Yes.
notebook
Yes,
and try
I'm
it
sorry
to
to tell
train.
you this. I know how much it is hard for this for you.
This is
Yes,
stressful for
I'm
yes,
you
sorry to
and
tell you this bad news today, early
yes,
yes,
today. I
like
appreciate
that.
it.
Yes,
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 yes.
I
I'm
understand your
afraid.
feeling. Some very, but yes, but as I told Dr. Dalia, reassurance is the best sympathy. To give the patient the bad
But,
news, then and follow it by
but
the good news, and then this is let the patient feel that he's supported and he's a way for there's some hope for his problem. That the best way is not just sorry. We will tell sorry in the first. I will try to tell sorry.
but but take care, to
I
Dr.
cannot say
Dr.
sorry too
Muhammad.
much. صراحة.
Take care. Be careful.
Yes, yes,
Be
yes,
careful
yes.
about false hope. Don't
Yeah,
reassure
yeah, no, no, yes,
with
yes, of
false
course.
hope. Yeah.
Yeah.
If they consider it as false hope, it,
About the majority of people is not leave disability. This is a good prognosis. About that, if we give the patient treated well, he will live near normal life. This is the reassurance, I think, and this is will give the patient the feeling of
but
support.
give it is too early to say because
yes,
really we
because we
don't
don't know
know.
the type. Yes.
Yes, yes, yeah.
Don't assume that she came in two attacks. This is the relapsing remitting. Maybe this is secondary progressive or primary progressive because it starts with attack, then it will progress. You don't know if they didn't mention to you this type is good prognostic one or relapsing remitting. Don't assume this is the relapsing remitting. Please stick to the scenario. What's written in the scenario,
Yes, yes,
try to follow. Okay. Okay, clear now, Dr. Muhammad.
yes,
But
yes, of
really,
course.
really, really, I appreciate that you practice for first time, and I'm happy that you are happy that you practice first time. Really, it's just overcome the first attempt. Next time you will do it in a perfect way, and you will do it frequently. Always the first time is the most difficult time. Thank you, Dr. Muhammad and Dr.
Yes,
Sandir.
welcome.
Thank you, everyone. Dr.
Thank you.
Rashid have written also some comments, even no guarantee about medication response. Yes, I agree. Don't be also expected what will happen. You don't know what will happen in the future. But we are trying to reassure, we are here, we are support.
Dr. Bassem, this is a prognostic value of the whole disease. It's the written disease about the prognosis. I'm not supposing this remitting or progressive remitting or progressive This is the patient about the MS. This is the whole, and about the management plan with the nerve doctor. I'm just telling him the figure that is already mentioned is the disease. That's to reassure the patient about the outcome, total outcome. What's the kind? I don't know. This is will be explained with the nerve doctor. I'm just not giving him that I will control the flare by corticosteroid. Then I will refer to the nerve doctor to manage lately after that.
Perfect.
About,
Okay.
this is what I mean. I'm not assigning the type. It's not my
Yes, I
responsibility.
know, but
I told her I will subside the flare very clearly. I will subside the flare, then I will send you to nerve doctor to he will give you the proper management. And about that, I give him reassurance that what I mean that the new revolutionary medicine coming in this field, this is facts. This is the facts.
yes,
I
we
give him the
agree.
facts.
Yes, we
I'm not.
agree for that. Yes,
Yeah, this
we
is the
agree for
issue.
that.
I'm not giving about the percentage. You already written percentage, but if I know better not to mention because if it's
Yes,
not wrong, yes, I agree with you. It may affect.
yes.
Yes.
It might be in your source. Okay, it's written in your source, but you don't know the examiner source. He might have another source which written there 50%. They don't want a number. By the way, they don't want to be clear in this expectation for how much and how many percentage. They want you to know simply and to deliver these things simply, as Dr. Aisha mentioned and everyone mentioned. Simply deliver the news to the patient without complication. Don't tell him 15, so he will think about the 58%. So, doctor, am I from the 58, 85% that will be living? How guarantee you are sure about? You don't know what expectation will happen. So don't give a number, okay? Just say some and others and few like this. Okay.
Okay.
Any question? Sorry, someone talking? Hello? Okay. Seems all satisfied. Thank you, Dr. Muhammad Gouda, Dr. Muhammad Sarder, Dr. Dalia, of course, Dr. Aisha, Dr. Rashid, everyone, Dr. Mayada, Dr. Maha as well. I hope I didn't miss any. Dr. Mona as well. Always your attendance make the meeting much helpful for others, and your comment always help others, not only my comment. Thank you for attendance, everyone. Hopefully see you tomorrow, inshallah.
Thank you.
Clinical day.
Thank you, Dr. Bassem.
Most welcome. Thank you for the practice today also. Dr. Fazl Rahman wrote a comment, sorry, Doctor. Communication is always about way to speaking, exactly, not about knowledge. So if you are speaking more than surrogate, be careful, more listening. Yes, exactly. Perfect. Yes. Thank you, Dr. Fazl Rahman. See you tomorrow, inshallah, with the clinical day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.